Good morning, everyone, and happy Teachers' Day. So my topic for today is treatment options for thrombocytopenia and cirrhosis and algorithmic approach. No disclosures. The contents of my slides would be an introduction, pathophysiology with possibly a therapeutic options with future directions. So coming to introduction, thrombocytopenia is one of the most common complications of liver diseases, prevalence almost up to 78% in cirrhotics. It's normally classified into mild, moderate, and severe with the incidence of nearly 16%. It's very important that we know the implication of thrombocytopenia because it is also a diagnostic clue, as we've seen in earlier conditions of liver cirrhosis. It is also a marker of prognosis. We have seen this in sepsis. We've seen this as a marker for predicting bleed as well. So there are a lot of importance of thrombocytopenia in liver disease. The pathophysiology, unfortunately, is still evolving, even though this has been known for a very long time. It is multifactorial. Sometimes even more than one mechanism can be played at one time. It is rapidly evolving. And the two most important mechanisms are decreased thrombopoietin production as well as platelet sequestration. So this is a diagram which depicts the various pathophysiological mechanisms. As you would see, one would be the etiology of liver disease, which would include ethanol as well as infections. Very few chances of an autoimmune related disorder. But the most important one would be the TPO production. This is what I will be focusing on because most of the therapeutic management in thrombocytopenia is based on the thrombopoietin production. And then you can see there is also splenic sequestration. So thrombopoietin was first cloned in 1994, and it has been shown that it is a major promoter as well as a regulator of platelet productions. It is primarily produced in the hepatocytes, so there are other sites of production as well. And its main function is to prevent apoptosis, increase the number size differentiation of megakaryocytes as well as platelets. So this diagram depicts that thrombopoietin has two receptors. One is the amino terminal and the other is a carboxy terminal. The amino terminal attaches itself to the CMPL receptor, which in turn is attached to the megakaryocytes, the platelets, as well as the progenitor stem cells, which in turn causes megakaryocytopoiesis, thrombopoiesis, as well as platelet release into circulation. The carboxy terminal is basically required for polypoid folding as well as for maintaining the half-life. Now in cirrhosis, it is debated that the main reason why thrombopoietin is implicated is because of an impaired hepatic function. The liver cell mass is actually reduced, thereby causing reduction in TPO levels. This diagram depicts the other various mechanisms that are actually being looked forward to in patients with cirrhosis. And this is a slide which shows that there are other mechanisms at play, which includes a von Willebrand factor. It includes mechanisms which involve platelet activation, platelet aggregation, as well as other mechanisms which require the release of ADP, serotonin, and calcium. And the crux of this presentation is to elucidate that most of the mechanisms which are still in play in thrombocytopenia are still to be investigated. And this slide, importantly, is the one where we need to focus on, which causes where there are intrinsic and extrinsic factors. And these are probably the reasons that we need to control when we control about thrombocytopenia. So when I started this, I thought that we'll have a common case that we normally see. And this is a 52-year-old male cirrhotic who presents to the endoscopy daycare and has a platelet count of 20,000 and has been asked to undergo an endoscopic band ligation. And now the patient wants to get it done as soon as possible. So what options does an endoscopist have while he is presenting, while he is doing? So this is the algorithmic approach which I've made, which we keep coming back to. And this I have seen that I've tried to divide it into mild, moderate, and severe. And you can see that if the patient's platelet counts are between 50 to 1,50,000, you normally look for the etiology, try and correct the etiology. You look for hepatic decompensation because severity of thrombocytopenia has been linked to hepatic decompensation. You look at portal hypertension, also sepsis, which is again another indicative marker of low platelets, as well as autoimmune. When you actually come to patients who have low platelet counts, this is where I think the role of platelet function is more important than in fact the thrombocytopenic, in fact the number of platelets. And then either if it's for therapeutic or prophylactic. If it's prophylactic, I think TPO agonists can be given. If it's therapeutic, then platelet transfusion. And if at all both the mechanisms fail, then maybe interventional like partial splenic embolization, which was discussed in the previous topic. Now, this is the most important thing is what is the recommended goal for platelets in pre-procedure. And as I was trying to find out, I actually found that there is actually no guidelines for patients with liver cirrhosis. All these guidelines are for the general population. Most of these guidelines are for individual preferences. The reason behind a platelet count of more than 50,000 is adequately preferred is possibly because of an adequate thrombin generation at 56,000, which was seen at an old paper in 2006. But this is the ASGE guideline, and if you look at very closely at this guideline, there are suggested platelet targets with low risk, moderate risk, and high risk procedures. But at the end, you would see that this is basically based on endoscopist preference or controversial and sometimes even considered high risk. So there is a lot of ambiguity, one, and these are not specific for liver diseases. This is for the general population that they look at targets for platelets. So whether we really need to correct the targets of platelets, that is where the concept of platelet functions would probably be more important. So now therapeutic options for thrombocytopenia, the most common one which was initially used was platelet transfusion. Then comes the TPO mimetics. There are interventional which has already been discussed in the previous topic, which I will not be discussing. So the first important one is platelet transfusion, and this has been the mainstay of treatment for a very long time, especially before the TPO agonists were actually in play. A normal single dose of platelet actually increases the platelet counts by nearly 30,000, but in cirrhosis this comes down to 12,000. And normally the counts are highest within the first hour of transfusion, so if any intervention has to be planned, it has to be done within the first hour itself. Now there are lots of disadvantages of actually having a platelet transfusion, and this ranges right from febrile transfusion reactions, from acute lung injury, from TRALI, from alloimmunization, as well as logistics, and as well as importantly cost. But very importantly, in a pathophysiological point of view, it has been shown that the platelet leukocyte aggregation is actually augmented in cirrhosis, and this is further increased by platelet transfusion. So actually platelet transfusions may be detrimental in patients with liver cirrhosis, and hence the need for transfusing platelets is still very much debated. So coming to the TPS agonists, and the first ones that were actually were romiplostin as well as L-thrombopag. Romiplostin very initially was only indicated for treatment of thrombocytopenia in the presence of chronic ITP, especially when the other therapies did not work, and this has not really been indicated in patients with liver disease with very few case reports. So the most important one, which was the first one which was discovered, was L-thrombopag, and this is basically a non-molecule, non-peptoid thrombopoietin receptor. It binds to the transmembrane domain of the TPO receptor, as well as activating the signal transduction pathways, causing more proliferation and differentiation of megakaryocytes. At present, its approval is for chronic ITP as well as only in liver disease with patients with chronic HCV infections, and most of the studies that have been done are in patients who are actually receiving interferon, and that is the indication at present for L-thrombopag. So the first study for L-thrombopag was in 2007, and this was looked in patients with cirrhosis associated with hepatitis C. And it was shown that patients who received L-thrombopag were patients who actually were given more of interferon, and there was a decreased reduction in platelet transfusion, and many of them completed at 12 weeks most of the studies. The dose that was typically given was 75 milligram, though even at 30 milligram they had shown that nearly 36% of the individuals were able to complete the treatment protocol. So they postulated that L-thrombopag was effective in raising the platelet count, thereby allowing the antiviral treatment for 12 weeks. But this is in 2007. Coming to 2012, and this was an article in NEJM, where again they used the same set of patients, though here, if you look at the etiology, there was more of hepatitis C, but there was also hepatitis B, alcoholic liver disease. And this is also probably the first trial which included child C patients. Most of the other patients were child A. And the median MELD score ranged from anywhere between 12 to 24. And this was L-thrombopag 75 mg for 14 days. And the primary endpoint was the requirement of platelet transfusion. And they had shown that nearly 72% of the patients who received L-thrombopag did not require any further platelet transfusions. But this study was not without many adverse events. And the most common adverse events that were actually seen was portal vein and splenic vein thrombosis. And in fact, this was seen in nearly 6 patients, and this actually led to the early termination of this trial. So even though this trial did postulate that treatment with L-thrombopag before invasive procedures reduced the need for platelet transfusion, it had also shown that there were more thrombotic events in portal venous system with L-thrombopag, thereby causing an early termination of this study. And another one that I would discuss is the L-thrombopag causing, again, an increase in HCV and cirrhosis. This was again a study which was done by the same group. But here you would see that the patients that they actually took were patients with child A and child B. So they did not take patients with child C. But here, very importantly, the overall side effects were nearly 20%, with many causing hepatic decompensation, close to 10%, and nearly 4% had increased risk of thrombosis. So again, it did increase platelet numbers, but not without many adverse events. So most of the studies have postulated that there's an increased risk of adverse events. At present, the only indication remains hepatitis C, There are need for further studies, and at present it probably is not indicated in patients with advanced cirrhosis of probably child B or late child B and child C onwards. So this was the newer TPA agonist which was approved in 2016, which was avatrombopag, again a small molecule TPO receptor agonist, has a very similar mechanism of action as compared to L-thrombopag, but surprisingly has a very good safety profile as compared to L-thrombopag in liver diseases. This was the first trial. This was a multi-center trial, also called as the ADAPT-1 and ADAPT-2 trial. This was based on primarily avatrombopag being given at the dose of either 60 mg in patients with platelet count of less than 40,000 or 40 mg if the platelet count was less than 50,000. And the patients were then randomized into two groups, which was one, the ADAPT-1 as well as the ADAPT-2 trial. And many of the patients completed the study, close to even 93% completed the study. And the salient features included that in the ADAPT-1 trial, nearly 66% of the patients did not require any further platelet transfusion. And these are all in the pre-procedural setting. So this is not in any other scenario. The only setting is pre-procedural settings. The duration of increase of platelets is normally seen almost up to a month after it has, though we see that probably about 3 weeks onwards after the giving of the doses, the platelet count starts to reduce by itself. It was also associated with few adverse events. It shows the adverse events are nearly in the range of 13 to 14%. But this study had postulated that most of the adverse events were mild, possibly moderate, but none of them actually had any portal vein thrombosis, giving a good safety profile for these patients. The other question was, how was it better than L-thrombopag? So some things that have actually changed over the past few years is the measurement of portal vein velocity. So when in the NEJM study they had found that L-thrombopag was associated with portal venous thrombosis, there's an inclusion criteria of portal vein velocity. So whenever we do give these medications, portal vein velocity prior to the procedure is extremely important. Also, I saw that the baseline platelet count in patients who received L-thrombopag versus avatrombopag was completely different. This was nearly in the range of 50 to 60,000, and which increased nearly up to 2 lakhs, possibly could be the reason for thrombosis. The child status, again, is child A and B for avatrombopag, not child C. And also the duration of therapy for avatrombopag is only 5 days as compared to 14 days in patients with L-thrombopag. The latest that has been approved is lusothrombopac, which is again a small molecule human TPO agonist. It has been approved initially in Japan for patients with thrombocytopenia with CLD undergoing an elective invasive procedure, possibly splenic embolization, locoregional therapy. And like I said, this is the latest TPO agonist which has been approved. So this was the first study, also called as the L+ trial. This was a multi-center randomized double-blind trial conducted across 81 centers in Japan. And lusothrombopac was given at a dose of 3 mg for a duration of 7 days pre-procedure, typically given almost 14 days before the procedure. The number of patients recruited were 97, and it has shown that 79% of the patients receiving lusothrombopac avoided platelet transfusions. Here again, if you would see that most of the indications were hepatitis C. So most of these were viral hepatitis rather than any other etiology of liver disease. So this diagram depicts the need for platelet transfusion, which is reduced in patients receiving lusothrombopac, nearly 79%. And one of the endpoints of the study was to either cause an increase of platelet count of more than 50,000 or a baseline increase of more than 20,000. So this was nearly 77% of the individuals achieved this target. And again, the duration of increase of platelets was seen up to nearly a month, with the highest being around the day 12 to day 14, and progressively going down by the day 35, 36. The adverse drug reactions were nearly 8 to 2%, with portal vein thrombosis seen in one patient with lusothrombopac. The other trial was the L+2 trial. This was recently published, and this had shown that with the primary endpoint of patients again not requiring platelet transfusions before an invasive procedure. Again, the dosing was 3 mg before 7 days. And it had shown that even in the intention to treat analysis, that nearly 64.4% of the individuals did not require any platelet transfusion when they received this medication lusothrombopac. So it was then postulated that lusothrombopac was superior to the placebo for reducing the need for platelet transfusion and achieved a durable platelet response in patients undergoing invasive procedures. So these are some of the contraindications, and I think the most important one being the prior history of portal vein thrombosis, as well as a relative contraindication of actually the portal vein flow. So it is extremely important when we actually prescribe these medications, we look at the portal vein flow. At present, it looks like child C or anybody with MELD more than 24 should not be receiving these medications. Platelet counts of more than 50,000, normally these are not indicated, and the rise in platelets is extremely important. And of course, we must look at other disease like advanced hepatocellular carcinomas, the other indication. Some of the other medical therapies which have been tried are recombinant humocytokines, which was interleukin 11, which is actually used in some of patients with chronic ITP. But in liver disease patients, there are significant toxicities, which includes ascites, edema, as well as lung failure, so hence they have not been used. Some of the other interleukins can be IL-3, IL-6, again not in use. Recombinant human TPO was again a trial which was done, but this was halted in view of development of neutralizing autoantibodies. So at present, the best option available is a TPO agonist. So very importantly for platelet, the most important, I think, as is evolving is the quality of platelets rather than the quantity of platelets. And this was studied at our center where we had taken patients with ACLF as well as patients with decompensated cirrhosis. And it was shown that patients with an optimum platelet count of more than 70,000, that was nearly 58 of them, had a very low platelet, even 34 of them had a very low platelet function. So even though there was an optimum platelet count, the platelet function was reduced. And hence I think it is more important to treat the platelet function rather than treating the platelet number. So maybe the possible other therapies would have to deal with that. The other was another very recent article which has been published, which had shown that in 111 patients, they had divided these into 3 groups. One had less than 50,000, the other was 50 to 100, and more than 100,000. They looked at the von Willebrand antigen, they looked at the ADAM13 activity, they looked at the platelet function, and they found there was no significant difference in size of aggregation, coverage of platelets, von Willebrand factor, as well as ADAMS13, even in the presence of thrombocytopenia. So it is very important that the concepts evolve and we actually look at the functionality of platelets rather than the counts of platelets. So coming back to my initial proposed algorithmic approach. So as I had mentioned earlier, I think etiology, some of the correctable factors which include, one is the etiology, the other would be portal hypertension. It has been shown in some disease that TIPS actually causes an improvement in platelet, but it has not been sustained for a very long period of time. Sepsis. If the patient, and since most of these studies have been done in pre-procedural settings, we probably only look at that aspect. So we look at the platelet function, and only if the platelet function is less than 1.5, which is the normal value for platelets, then either we divide them into patients who require it for either therapeutics or for prophylaxis. If it's for therapeutics, even though now it's an actively bleeding patient, we still may have to give platelet transfusion, but we need to keep a watch on the other etiological factors which include sepsis, they include portal hypertension. If it's for prophylaxis, TPO agonists can still be given, but at the same time, what is very important to remember is that cirrhosis per se is a disease not of platelet dysfunction, but of platelet activation. So it is very important that these TPO agonists are actually monitored. And if there is frequent need of platelet transfusion and more of adverse events, then possibly the role of other interventional arms like PSC or even splenectomy can be thought of. So very importantly, the future directions, and I think this is where we really need to focus on, which is that, one, we do not have guidelines for thrombocytopenia in patients with chronic liver disease, so this has to be definitely incorporated. Coagulopathy-based indices for correction is very important. And in fact, there's a recent study in ACLF where they have actually corrected the coagulopathy indices, mostly the MCF values, and they have found that that was more superior. We need to think of platelet function rather than the number. So if the platelet function is within normal limits, probably the total counts really don't matter. And therapies for reduction of von Willebrand factor and ADAM-TS are actually the crux, because most of the other pathophysiology mechanism, these two probably form the most important aspect of the pathophysiology in patients with thrombocytopenia and cirrhosis, and it requires a shift right now in the treatment management. Thank you.